Okay, in our video series of pulmonology lectures, in this video we are going to talk about restrictive lung diseases. We are also going to discuss interstitial lung diseases, pneumoconiosis, hypersensitivity pneumonitis, idiopathic pulmonary fibrosis in detail in this video. First of all, what is restrictive lung disease? Restrictive lung disease is the decreased ability of the lungs to expand fully. The lungs cannot expand fully, therefore they cannot take the air in properly. Now there can be two causes that can result in a restrictive lung disease. There can be extrinsic causes outside the lungs involving the chest wall, or there can be intrinsic causes. Something is wrong with the lungs, something is wrong with the lung tissue. They include the intrinsic causes. Now what can be the extrinsic causes that will make it difficult for the lungs to expand fully? They include chest wall abnormalities like chest wall stiffness. If the chest wall is stiff, like in the old age patients, the chest wall gets stiff and it is not compliant and it cannot expand fully, therefore the lungs cannot expand. Also, in patients with kyphoscoliosis, where the chest wall is deformed, and where the chest wall is deformed, it cannot expand fully, therefore the lungs cannot expand. Or in patients with muscle weakness, muscle paralysis like diaphragm paralysis, paralysis of the intercostal muscles, therefore the chest cannot expand properly. When the chest cannot expand, the lungs cannot expand. It occurs in the patients of Guillain-Barré syndrome, myasthenia gravis, where there is muscle weakness and muscle paralysis. And in patients with severe obesity, where there is large amount of fats on the chest, that can result in difficulty of the chest to expand properly. When the chest cannot expand, the lungs cannot expand fully, and that results in a restrictive lung disease. So these are the extrinsic causes. Our main focus of this video is the intrinsic causes. What are the pathologies that involve the lungs, that damage the lungs and result in the lungs to not expand full properly? These intrinsic causes include the causes that damage the lungs, like interstitial lung diseases. What are interstitial lung diseases? Our main focus is all the interstitial lung diseases, all the interstitial pathologies that damage the lungs. We have a case here. A 65-year-old man comes to your clinic and tells you, the doctor, for the last 3 months I have been having this shortness of breath and dyspnea. Initially, this shortness of breath was only on exertion, but now this shortness of breath is even there when I am sitting down, when I am resting. When you auscultate the patient's chest, you feel fine crackles in the chest. You listen to fine crackles in the chest. When you take the history, the patient is smoker and patient does pottery work in his leisure time. This patient, when you perform the chest x-ray, you see a chest x-ray like this. Look at all the hazy parenchymal changes in the lungs. Then you order a HRCT, high resolution CT, and when you receive the high resolution CT, you receive a picture like this, where there is total destruction of the lungs. There is a honeycombing pattern. These are not normal lungs. This shows total destruction of the lung. This patient is having interstitial lung disease. Now, what is the cause of this interstitial lung disease? Why is there destruction of lungs in this patient? Today we are going to talk about that. Interstitial lung disease is a group of disorder characterized by inflammation of the alveolar wall, resulting in widespread fibrosis and collagen deposition. Remember, there is inflammation of the alveolar wall, and when the alveolar wall gets inflamed, it results in fibrosis. Fibrosis forms non-functional tissue in the lungs. Fibrosis makes it difficult for the lungs to expand fully. Therefore, the lungs cannot expand. Therefore, they cannot fill up with air. That results in restrictive lung disease, interstitial lung disease. There is collagen deposition, there is inflammation of the alveolar wall that results in widespread fibrosis, and normal elasticity of the lungs is lost and the lungs cannot expand properly. The most common symptom, the most common presentation would be dry cough and progressive exertional dyspnea. Progressive exertional dyspnea, initially it will be on exertion, but later on it will also be present on the rest. Now, what is the pathophysiology? Remember, interstitial lung diseases are a group of diseases. There are many diseases that occur in interstitial lung diseases. We will discuss only the most important ones. And there are many diseases in interstitial lung diseases where you don't even know what is the trigger of the disease. But a proposed mechanism is that sometimes whenever patient inhales any foreign particles and that foreign particle is taken up by the alveolar macrophages, that activates the immune system, and when it activates the immune system, there is an inflammatory reaction, and that inflammatory reaction destroys the lungs. That results in scarring, collagen deposition, granuloma formation in the lungs, and that immune response damages the lungs. So interstitial lung disease is a group of diseases with many diseases in it. It includes pneumoconiosis, hypersensitivity pneumonitis, idiopathic pulmonary fibrosis, where sometimes you know the trigger and sometimes you don't know the trigger. But the proposed mechanism is that sometimes a foreign agent, a foreign particle gets inside the alveoli, and inside the alveoli it is taken up by the macrophages. When the macrophages take it up, they result in inflammation. They start the inflammatory reaction. They produce cytokines that result in inflammation, and that inflammation destroys the alveolar wall. When that alveolar wall is destroyed, then fibroblasts come into play, and fibroblasts try to repair this alveolar wall. When fibroblasts try to repair this alveolar wall, what they do is that they deposit collagen over here. That collagen deposition results in fibrosis of the lungs, and the normal elasticity of the alveoli is lost. The alveoli cannot expand properly now. Therefore, these patients, the lungs cannot expand fully. Therefore, these patients are having restrictive lung disease, interstitial lung disease. Initially, these patients will be having exertional dyspnea, and later on this dyspnea will be also present at rest. When you observe these patients, what you would see in these patients is that these patients will be having shortness of breath, and they will be taking short breaths, and they will be taking the breaths more frequently like this. So the patients may present with high frequency, increased number of breaths, and shallow breathing to compensate for dyspnea. So these patients will be taking rapid breaths and shallow breaths again and again. There will be persistent dry cough. When you auscultate the chest of these patients, what you will hear is that on the bases of the lungs, you will find inspiratory crackles. Fine crackles will be there, dry crackles will be there, and they will be just like Velcro-like rails. When you open up a Velcro is this material. When you open this material, this Velcro, the sound that it produces, exact same sound is found in the lungs. This is a dry sound. There is no wet crackle present in these lungs because there is no pulmonary edema. There are dry crackles, and that dry crackles are due to fibrosis of the lungs. In the advanced stages, what you would see is that there will be digital clubbing of the nails due to chronic hypoxia. Due to chronic hypoxia, inflammatory mediators like platelet-derived growth factors will be released, and these growth factors causes growth of the connective tissue, and the nails will be rounded. Digital clubbing will be seen. Cyanosis due to hypoxia, because the functional layer of the alveoli is fibrosed and the gas exchange cannot take place. There can be loud inspiratory wheezes in the later stages. Remember, in the initial stages, in most common presentation would be inspiratory crackles, but in some patients in the advanced stages, you would also hear loud inspiratory wheezes in these patients. Whenever you suspect interstitial lung diseases, always take history. Always try to find out what is the trigger, what is the cause of this interstitial lung disease. Ask about the medication, especially ask about bleomycin, busulfan, ask about methotrexate intake, ask about radiation history, whether the patient had any exposure to the radiation, because radiation can also cause interstitial lung disease. Ask about the previous jobs that patient had, any occupational exposure to asbestos, silica, beryllium, or to cotton, because these things can also trigger this inflammatory reaction. Any past medical history like any connective tissue disease, rheumatoid arthritis, autoimmune conditions can cause inflammation and continuous fibrosis of the lung. Rheumatoid arthritis, inflammatory bowel disease, allergic rhinitis, malignancy, always take smoking history. Always take smoking history. So whenever you suspect interstitial lung disease in a patient, always to ask about the triggers. Try to find out the triggers, and in many cases you won't be able to find the trigger. So whenever a patient of interstitial lung disease comes to you, always take a proper history and try to find out the trigger. And in some patients, you won't be able to find out any trigger. Now, in the lung conditions, we had restrictive lung diseases. In the restrictive lung diseases, we had intrinsic causes, extrinsic causes. Extrinsic causes involving the chest wall and muscles. Intrinsic causes that involves the lung parenchyma, where there is damage to the lungs. In the intrinsic causes, we have interstitial lung disease. Now remember, interstitial lung disease itself is a group of diseases, and there are many other conditions that are present in the interstitial lung diseases, but we will memorize and discuss only the most important ones that you need to know for your exams and for your clinical practice. Now in many cases you will be able to find the exposure, whether the patient is exposed to something and that is resulting in interstitial lung diseases, any dust particle, any employment, smoking. But in some cases, when you take the history, there is no exposure, but still the patient is having interstitial lung disease. The patient has a job where there is no exposure to dust particles, the patient is non-smoker. In such cases, patient has interstitial lung disease, but the exposure is unknown. That is called as idiopathic interstitial pneumonia. And there are many conditions that are covered in idiopathic interstitial pneumonia. In many cases, you will be able to find the exposure. When the exposure is known, it can be either a pneumoconiosis. What is pneumoconiosis? We'll discuss that in detail. Or it can be drugs like bleomycin, busulfan, methotrexate. Must memorize these drugs because these drugs are commonly asked in exams. Hypersensitivity pneumonitis can also result in interstitial lung disease. What is hypersensitivity pneumonitis? We will discuss that in detail in our video series. Now, first of all, we will cover the idiopathic interstitial pneumonia. In the interstitial lung diseases, idiopathic interstitial pneumonias are idiopathic, where you don't know which exposure is causing this interstitial lung disease, where you are unable to find the exposure. Now there are many conditions in idiopathic interstitial pneumonia, but the most important one that you need to know is idiopathic pulmonary fibrosis. So we are only going to discuss idiopathic pulmonary fibrosis in this video. I have mentioned the other conditions as well: acute interstitial pneumonia, cryptogenic organizing pneumonia. In all these conditions there is interstitial lung disease, fibrosis of the lung, but we do not know any cause, what is causing this interstitial lung disease. The only condition that you must know is idiopathic pulmonary fibrosis. Other than that, sarcoidosis, the very famous disease, sarcoidosis is also an idiopathic interstitial lung disease. I have discussed sarcoidosis in detail in my video on sarcoidosis. You can check out the video, link given in the description below. So the most important one is idiopathic pulmonary fibrosis that we are going to cover in this video. Now, there will be cases when you know the cause of exposure, when you know which dust is causing the exposure. They include pneumoconiosis and hypersensitivity pneumonitis. Pneumoconiosis include asbestosis, where there is exposure to asbestos, silicosis, where there is exposure to silica, anthracosis, where there is exposure to coal dust, berylliosis, where there is exposure to beryllium, bicyanosis, exposure to cotton. In the hypersensitivity pneumonitis, that is farmer's lung, pigeon breeder's lung, patients who are having pigeons at their home, chemical worker lung. What we are going to do is that we are going to talk about and discuss idiopathic pulmonary fibrosis in detail in this video. In the next video, we will be covering pneumoconiosis, all the important pneumoconiosis. And in the third video, we will be discussing hypersensitivity pneumonitis. We will divide these into different sections so that it will be easy for you to memorize all this information. Interstitial lung diseases is a very broad topic with so many conditions in it. I have only concluded it down to the most important ones that you need to know for your exams and for your clinical practice. Remember, autoimmune conditions can also cause interstitial lung diseases like rheumatoid arthritis, connective tissue diseases. SLE can result in interstitial lung disease as well. Now, we'll be discussing idiopathic pulmonary fibrosis in detail in this video. What is idiopathic pulmonary fibrosis? How does it present and how do you treat it? We have a case here. A 60-year-old man comes to you with shortness of breath on walking. When you take the history, patient takes no medication, there are no comorbidities, he was a totally healthy man. There was no smoking history. Patient has an office job where he is sitting in an office the whole day, he exercises regularly, there are no risk factors, there are no exposures, and the patient is having interstitial lung disease. When you auscultate the chest, there are coarse crackles present. When you examine the patient's finger, there is clubbing present. When you examine the patient's legs, you find trace pedal edema and jugular venous distension. Why are you seeing coarse trace pedal edema and jugular venous distension? Because when the lungs are damaged, the right side of the heart starts failing. That is called as cor pulmonale, because the heart cannot push the blood properly to the damaged lungs. Therefore, right-sided heart failure takes place that results in trace pedal edema and jugular venous distension. This patient has no risk factor. We don't know what is causing this interstitial lung disease. The cause is not known, the exposure is not known. This is a case of idiopathic pulmonary fibrosis. If the patient is a smoker or if the patient is taking any medication, we would say this is not an idiopathic fibrosis. But since this patient is having no exposure, we say that this patient is having idiopathic pulmonary fibrosis. It is the most common type of interstitial lung disease. Most commonly, you won't be able to find any exposure. Irreversible pulmonary fibrosis and impaired pulmonary function because the alveoli are fibrosed and gaseous exchange cannot take place. The lungs cannot expand fully. Most common age group is 50 to 70 years of age. Men are equally affected as women. You will be able to find clubbing in these patients due to chronic hypoxia. When this patient come to you with shortness of breath, you will perform X-ray, and on X-ray you will see either reticular or reticulonodular pattern. Now, what is reticular pattern? Reticular pattern, when you see lines like these on the chest X-ray. Nodular pattern is when you see small dots like these, that is called as a nodular pattern. Now, these are different pattern of fibrosis. Whenever fibrosis in the lung is taking place, it can either appear as a reticular pattern, or it can appear as a nodular pattern, or it can appear as a reticulonodular pattern where you will be able to see both the lines as well as the small dots in it. Now, this is a patient having a chest X-ray of idiopathic pulmonary fibrosis, and look at the reticular pattern, look at the lines, you can easily appreciate the lines, and you will be able to better appreciate these lines when you see a nodular pattern of chest X-ray. This is an image showing nodular pattern. Now, if you see, look at the small spots, look at the nodules, look at the small nodules. These nodules have resulted from the fibrosis of lungs. This is a picture showing a reticulonodular pattern where you are able to appreciate the nodules. Look over here, this is a nodule, this is a nodule, and you are also able to appreciate the lines. The lines are also there. The lines are also there. If you focus on this X-ray, you will be able to find the lines as well as the nodules. That is called as a reticulonodular pattern in interstitial lung diseases. Now, in patients with idiopathic pulmonary fibrosis or interstitial lung disease, you cannot just rely on chest X-ray. Chest X-ray is an initial test that will tell you that something is going wrong with the lung. What you can do is that you can take a detailed picture of the lungs in an HRCT. High resolution CT will show you a detailed picture of the patient's lung, but HRCT has high level of radiation exposure as well. Now, in these patients, HRCT is done for the diagnosis. On HRCT, you will be able to find ground glass appearance and honeycomb pattern. This is a picture showing honeycomb pattern. This is a classical picture of honeycomb pattern. This is due to destruction of the alveoli, or the alveoli are destroyed. There is fibrosis in the lung. Excessive collagen deposition is causing the lungs to get more white. This should have been more black. This is the picture showing ground glass appearance. Look at the ground glass appearance in idiopathic pulmonary fibrosis. So, HRCT will give you a more detailed picture and is needed for the diagnosis. Coming to the treatment of idiopathic pulmonary fibrosis, remember, idiopathic pulmonary fibrosis is not a very good condition. It has a poor prognosis and the treatment options are limited. If a patient develops idiopathic pulmonary fibrosis, that patient is quite unlucky patient, and because we do not have any treatment options for this condition. There are limited options. Majority of the patients, greater than 70%, even if you treat them, they do not improve with the treatment. That means that we do not have proper treatments. Only you can do is that you can give supplemental oxygen if the patient is having hypoxia. There are certain drugs, anti-fibrotic drugs, that are there to stop the fibrosis, which are not effective in the later stages. Nintedanib or pirfenidone, they slow the progression of disease, but the prognosis is poor in these patients. You vaccinate these patients against COVID-19, pneumococcal vaccine, influenza vaccine. The treatment option that we have in these patients is lung transplant. Lung transplant can improve mortality in these patients, can improve the patient's chances of survival, but availability of lungs for transplant, the donor lungs availability, is also a huge problem. Antifibrotic drugs, pirfenidone and nintedanib mechanism has been explained in this slide. Pirfenidone inhibits transforming growth factor beta, which causes the collagen deposition. Nintedanib inhibits tyrosine kinase and slows down the fibrogenic factors like VEGF, PDGF, FGF. So, but these are not very effective drugs. The treatment options are very limited. Now you'll be thinking that this is an autoimmune condition where there is excessive immune response. Steroids should be used to stop this. In idiopathic pulmonary fibrosis, steroids have no benefit. Especially in the cases of idiopathic pulmonary fibrosis, steroids have no role and they are not given. Complications include pulmonary hypertension. Since the lungs are getting damaged, lungs are getting fibrotic, the vessels, there is chronic hypoxia, and whenever there is hypoxia in the lungs, the vessels constrict, and chronically these patients are having hypoxia resulting in chronic vasoconstriction of the lungs. The complication of idiopathic pulmonary fibrosis include pulmonary hypertension. Remember, these patients are having constant level of hypoxia in the lungs. Therefore, whenever there is hypoxia, the pulmonary vessels vasoconstrict, and constant vasoconstriction of these pulmonary vessels results in pulmonary hypertension. Whenever there is pulmonary hypertension, the right side of the heart has to push blood with more force. The right side of the heart is overworked. That can result in right-sided heart failure. Therefore, the patient had trace pedal edema, raised JVP. Prognosis is poor. Respiratory failure occurs in 3 to 7 years after diagnosis. Before going into the summary, if you like my video, please make sure to click on the subscribe button. And make sure to watch my next video on pneumoconiosis. I have discussed pneumoconiosis in detail, asbestosis, silicosis, berylliosis. And in the next video, I'll also be talking about hypersensitivity pneumonitis. Make sure to check those videos out. In summary, we talked about what is restrictive lung disease. In the restrictive lung disease, we talked about intrinsic lung diseases, interstitial lung diseases in detail. What is interstitial lung disease? What is the pathophysiology? How it causes fibrosis and the alveoli cannot expand properly. Exertional dyspnea, most common symptom associated with dry cough and velcro-like rail zone auscultation. Digital clubbing is seen. Always take proper history, occupational history, smoking history. In many cases, the exposure will be known, like pneumoconiosis, drugs, hypersensitivity pneumonitis. In many cases, exposure will not be known. The causes, the diseases where their exposure is not known, sarcoidosis and idiopathic pulmonary fibrosis being the most important one. The causes of pneumoconiosis and hypersensitivity pneumonitis. Then we talked about idiopathic pulmonary fibrosis. We talked about a case that we had, definition of and the diagnosis on HRCT, chest X-ray finding showing reticulonodular pattern, and the HRCT appearance, honeycomb, ground glass appearance. Treatment options are limited. Prognosis is poor. If you liked my video, please make sure to click on the subscribe button and make sure to check out my other lectures on pulmonology lecture series, cardiology lectures, emergency medicine lectures, neurology lectures. The link of those videos is given in the description below. Thank you very much.